Okay, you've got a painting in front of you, or a photograph of a painting. Van Gogh, sunflowers. Who likes this painting? Okay, and who doesn't? Right. So if you had sort of 170 million pounds, you wouldn't buy it. You were wondering what is going on here, and there were situational influences, and lots of you were very quiet. You did not know why I'm doing this. This has nothing to do with cultural competency. And you were wondering what's going on, and at the same time, there were very clear polarizing approaches. Even if you had sort of 200 million in your back pocket, you were not prepared to bid for one of those paintings. And just think about some of the reasons for your choice. Because it's a famous painting, because it's unconventional, it's geometric shape, because it's, reminds me of my nurse who, maternal nurturing, and the fact that, Botticelli aroused no emotions at all. Or if it did, you did not feel comfortable in sharing that, which is fine. We all do that. And there were certainly group influences, and there were, why is he asking us this? So there's a kind of element of subtle threat. If I say I don't like a very famous painting, how is it going to reflect on me? And all of these feelings are very strongly influenced by our cultural upbringing. Are we open enough to share our feelings, or we just hold back? Do we say things only in safe spaces, or do we blurt it out wherever it is? Do we feel shy, or do we feel too much, in your face? And it's also worth remembering that every situation that we are in, our responses are molded by factors, some of which we know and others we don't. The ones we know is the way we've been brought up, our cultural values, and so on and so forth. These are the questions from the UK. BAME was the favorite word term till recently, and the government decided that they couldn't cope with it. Originally, BAME meant black and minority ethnic groups, till one of the members of parliament stood up in the House of Commons, and rather than saying "and," he introduced Asian, so it became black, Asian, minority ethnic groups. Now, terms are important, but they're also problematic, because you're comparing skin color with geographical origin with minority status, and you're lumping them all together. So what that tells us that there is something else going on, and some of these figures are just that, admissions from BAME groups, and I'm going to continue using it till, the government tells me that I can't, are more likely to be admitted to psychiatric hospitals, more likely to be treated with higher doses of medication, more likely to be treated compulsorily, more likely to spend a longer time before getting into care, and more likely to be placed in seclusion and turned away when seeking help, less likely to get psychotherapies. And from your point of view, that is the crux. That somehow, these poor black Asian folk can't think for themselves, and they need they're really not used to psychotherapy. Yes, of course, there are problems, and I will come back to that later in the talk in terms of we touched upon egocentric psychotherapies yesterday. But equally importantly, it's worth bearing in mind that there was a very famous Indian psychoanalyst, Girindra Sekhar Bose, who did the Indian version of psychoanalysis, and he wrote to Freud, and Freud ignored his letter because it was coming from, somewhere in the sticks. He then sent a statue of Vishnu, supreme Hindu god, in an ivory, it was an ivory statue to Freud, and then, so it just Freud then responded, and till his dying day, the statue sat on his table. So there is a book called Vishnu on Freud's Desk, which gives the background of psychoanalysis in India, but we'll come back to that. So we've talked about Bayman. I'm not going to go through that. Just to highlight, since 1985, there have been reports about variation in rates of mental illnesses, in rates of help seeking, and outcomes. It's nothing new. But every year, every 2 years, politicians and professionals keep coming up with more reports and more reports and more reports. But just don't ask me to do anything. I've done the report. Now go away, stop bothering me. And that's the frustration that you need to carry as therapists, because you, in theory, are the advocates for your patients from minority groups, no matter what it is. And we talked about definitions of culture yesterday, and I'm not going to go through that. This comes from agriculture. It comes from collective identity. It's about civilization. As I was saying yesterday, that so-and-so is cultured. And so that definition of civilization takes that role. And then it's a way of life, values, customs, beliefs, knowledge, institutions. So all of the humanly constructed and socially transmitted aspects of the environment. So many levels of social organization, institutions, communities, etc. So from your perspective, what you need to bear in mind is that cultures are unique in as far as they're shaped by a group of people. So even before we are born, your parents decide, and these days you can identify the biological sex of the infant and the baby, so you can paint the room blue or pink or yellow depending upon your color. So you're insinuating a kind of preconception for the child even before the child is born. So whether you buy them trains or buy them dolls is giving a very clear message. And what we also need to bear in mind is that cultures are dynamic. They keep changing. We change cultures, cultures change us. It's an ongoing phenomenon. And even within the same culture, people change at different ways. So it's about customs, beliefs, values, and needs to be differentiated from ethnicity. Ethnicity is self-ascription, how I see myself. I could argue that part of my cultural upbringing was Punjabi, because I was born in post-partition Punjab on the Indian side. But there are lots of similarities across the border with Pakistan. And there's a lot of commonality in Punjabi culture. Language, script may be different, language, cuisine, music, attitude. So, but on the other hand, my ethnicity, according to the British census, I am British Indian. So, two biological terms. Biological? No, I don't mean that. Geographical terms. It's an early start. So, the thing that we need to bear in mind is that culture molds us. Cultures lead us to think in the way the culture expects us to. So it's about our cognitive development, it's about our social development, but it's also partly about emotional development, but more important than that is how we express emotions. For a very long time, the British prided themselves as being, stiff upper lip, nothing can faze me. And then, there was a particular point when this, famous footballer cried on the pitch, and then, the whole country sort of started crying. So there was a shift. And it is, but shared meanings. So what we need to be thinking about is the same kind of societies have different kinds of components, definitions, descriptions. USA prides itself as being a melting pot. Canada prides itself as being a rainbow nation, that every community is there, but it forms a whole rainbow. Britain sees itself as multicultural. Australia sees itself as English-speaking and non-English-speaking. So what that tells us is that there isn't a single uniform model of cultural perceptions. And cultures influence the way we think. They affect child rearing. Religious upbringing, forces us to have certain values and behaviors. So we are born, play, learn, work, and live in a culture. We're not born with a culture. And whatever we do, subconsciously or consciously, we influence the culture we are living in, and the culture is influencing us without us realizing that that's what's going on. And because, there are different ways, and I just told you that, I see myself as Punjabi. So that's one of my identities, but it's also being male, Indian origin, settled in Britain, psychiatrist, medic. So all those identities, and we touched upon sort of micro-identities yesterday, and I'll come back to that, but just to, again, Geert Hofstede was a Dutch sociologist who worked with multinational companies for a number of years, and he looked at the cultures of organizations, and those bits were then applied to society as a whole. So the cultures can be sociocentric, egocentric, i.e. collectivist or individualistic. They can be masculine or feminine. Cultures can avoid uncertainty. Cultures can be closed, open, tight, loose. And just to illustrate some of the differences, sociocentric cultures are the focus is on the family, on the tribe, on the community. It's not about who you are. It's about, who's your grandfather, which family do you come from. Status is predetermined. So no matter how rich you are, you will always be seen as, even now when I go back, I'm always seen as grandson of so-and-so or son of so-and-so rather than an individual in my own right. I have little or no choice in that status. I'm just stuck with it. And people are interdependent, and you work for the group advance rather than individual advance. Egocentric, on the other hand, the focus is on nuclear family. Me, my partner, my children, at a push, my parents or my partner's parents, and that's about it. Focus is very much on status. What can I achieve? How do I achieve it? And very weak social links. Now that distinction is particularly important for a number of reasons. Now think of your practice. If you are faced with a sociocentric person from a sociocentric society who's migrated to an egocentric society, yeah? With me so far? If they're not surrounded with sociocentric individuals, they're surrounded with egocentric individuals, there's likely to be a degree of conflict or tension. How do you deal with that? If you're an egocentric individual from a sociocentric society, that's fine. And you move into an egocentric society, but you're surrounded by sociocentric people from your community, you're going to have a cultural conflict of a different kind. So the point that I'm making is that not everybody from a sociocentric society is going to be sociocentric, but they may respond in ways which may not be very settling for them. And the conflict, as I said yesterday, that 3 things that you need to bear in mind when you're dealing with migrants are culture conflict, culture shock, and cultural bereavement. Cultural bereavement is about what we've left behind, and we're carrying it in our head. But it might be material possessions, it might be friendships, it might be relationships. Culture shock is you're just going to show up and say, where have I landed? And I still remember, when I landed in London, middle of November, dark, cold day. It was 3 o'clock in the afternoon, it was pitch dark. And my instinctive response was, where have I landed? You're used to staying up till midnight. How am I going to stay up for 9 hours when it's dark outside? And over the years I've got used to it, so I get a culture shock of a different kind. And then there are, again, I touched upon this yesterday, there are linear active cultures where people do one thing at a time, concentrate on that, do it within a scheduled period. And multi-active cultures, not interested in deadlines or in schedules, consider reality to be more important, don't like conversations unfinished, so carry on doing 4 things at the same time. So again, there are examples. Linear active cultures are, Germany, Scandinavians, Austria, Australasia, Japan, Belgians, French, etc. And reactive cultures, again, there are challenges that we need to be thinking about. From your point of view, one of the other things that you need to bear in mind is that when we talk about masculine cultures and feminine cultures, what does it mean? 2 examples. Masculine cultures, gender roles are very clearly defined. Men are supposed to go out, do some work, bring money in. Women are supposed to stay at home, look after the family and the children. Men have no role in bringing up children. In feminine cultures, men and women have equal responsibility. So if you look at the rates of, in Scandinavia, they're considered as feminine cultures. Men and women are equal on all levels, equal responsibility. And in Denmark, I think men get about 6 months of paternity leave. fully paid, and the salary differential between men and women is zero. Whereas in masculine cultures, men tend to earn more. There's generally more aggression as well. So the other point that I raised yesterday, and it's worth repeating, is that culture is also, we as professionals have culture, part of the way we've been trained, where we've trained. As I said yesterday, that there's a difference between culture in this university and Chinese University of Hong Kong. You imbibe those things without being conscious of it. And as professionals, whether we are therapists or as with psychiatrists or psychologists or whatever, as professionals, we have a jargon. So we use that jargon so that we can exclude everybody else. So that's our culture. So what that means is that when a patient is sitting in front of you, chances of conflict are fairly high, because you then end up trying to deal with what the patient is telling you. So cultures are dynamic. They can change subtly. They change subtly, but they can change acutely. Following a war or conflict or trauma, things suddenly, or invasion, things suddenly change. Culture is integrated in people's lives. You can't sort of separate it out. And we acquire culture in different ways, and as I said, it influences cognitive and social development. So professionals' cultures, and they're likely to be microcultures. And I touched upon the difference between disease and illness yesterday. We as clinicians are interested in diseases because we're interested in looking at pathology. The consequences of that pathology affect patients' social functioning, their relationship, their job, ability to earn money. Most patients can live with their symptoms as long as they have some money in their pocket, they have relationships, they've got a roof over their head. But we focus on getting rid of the symptoms. And quite often those cultural expectations play a role in that, both our cultures and the patient's culture. So we need to be conscious of that. And those social consequences are the illness. And sickness is something very different. In Hong Kong, do you get sick notes from doctors if you're going off sick? How many days? 7 days. Depends upon, okay. Has it always been 7 days? Exactly. So what's changed in the society? So society changed its definitions of sickness. And similarly in the UK, there used to be that, for first 24 hours, you didn't need a certificate, sickness certificate or sick note. You could just say, well, I'm off sick today, and that was fine. But then it gradually they said, oh, well, it's too much hassle for doctors to write sick certificates, so let's make it 72 hours. What changed? So society then is defining sickness. Although this figure is showing the relationship between man, culture, and society, but I want you to think about man in the middle. And in this context, I am also including women. So surrounded by family, surrounded by community, surrounded by society, surrounded by culture, surrounded by nation. So there's multiple, sorry. So what we need to be aware of, in whatever we do, patients are at the core of it. individual who's sitting in front of you is at the core of any kind of interaction. I touched upon idioms of distress yesterday. These are very much culturally and socially constructed. My heart is sinking, I feel gutted, I've got butterflies in my stomach. These are all sort of culturally influenced idioms. And what we need to be thinking about is that those is the culture which constructs dis-ease, illnesses, and where we seek help from. So, one of the big tragedies of Western medicine has been this Cartesian mind-body dualism. Descartes was told quite clearly by the church that, body is the doctor's problem, soul, mind is the church's. And I think if you read him carefully, he's not that dogmatic, but his followers became much more dogmatic, and they sort of said, mind and body are separate, as if mind doesn't talk to the body and body doesn't respond to stress in your mind. Culture affects all aspects of the illness: generation of symptoms, expression, experience of symptoms and coping, help seeking, and management of symptoms. So there are 6 ways culture affects mental health. And this is the work of Wenxing Sheng, who was based in Hawaii. I think he might have been Taiwanese originally. And he talks at length about how cultures can be pathogenic, i.e. they cause symptoms, they affect people in certain ways, they modify symptom presentation, and they elaborate symptoms, and they exist across, but are more common in certain cultures. And then cultures can be pathoreactive. And very quickly, I'm going to give you some examples. So cultures cause symptoms, and we've talked about cultural bereavement, we talked about cultural conflict, where, culture produces those symptoms. And Professor Yap from this very university described in the 1960s culture-bound syndromes of different kinds. Now, one of the big challenges about culture-bound syndromes is that things keep changing, cultures keep changing. And there were something like 179, 199 culture-bound syndromes once upon a time, and they're now down to about 7. So what's changed? Lots of things. Firstly, in Malayan Peninsula, when you were feeling agitated and you were feeling really angry with somebody, you sort of went around hitting people on the head, and it was called running amok. The Brits, in their infinite wisdom, decided that this was illegal. So patients who ran amok ended up in prison. Now, if you look at, there's this rather tragic incident yesterday, I think in some school in America, this woman took a gun and shot 6 people. But that is running amok, except that it's more dangerous if you have access to guns. Similarly, the whole idea of semen loss anxiety, which is incredibly common in the Indian subcontinent. Men get very worked up, and there's been description that women also get, if they have a vaginal discharge, they start to feel very run down, depressed, anxious. If you look at the history of semen loss anxiety, in 19th century Britain and America during the Industrial Revolution, it was very common. And Kellogg invented cornflakes as a treatment for semen loss anxiety.
Sorry, could you just say a bit more? What is semen loss
People, if, either through masturbation or nocturnal emission, if you lose semen, you start to feel weak, you start to feel depressed, you start to feel anxious. Um, so next time you're having cornflakes, just think what you're having and why you're having it. It's beginning to disappear from the Indian subcontinent as well. You don't see as much as you used to. So there is something to say that there are changes in cultures which change symptoms, conditions, etc. Cultures affect groups of people in specific ways, and inevitably it depends upon your personality, your educational status, your economic status, and symptom contents vary. So if you look at schizophrenia, for example, different cultures will have different kinds of components and experiences. Cultures modify symptom presentation. And certainly when I was training in psychiatry in the 80s, we still saw elderly patients who were really frightened because the mustard gas was coming from underneath their bed, which was making them mad. That then gave way to CIAs after me, or aliens have come, and and now it's social media. It's all about what's being said on the Facebook and so on and so forth. So things are changing. So culture elaborates symptoms and distress. So we talked about running amok. Culture facilitates certain illnesses. And we know the rates of suicide vary across countries. Rates of alcohol abuse vary, and we were talking earlier about rates of gambling. And they're very strongly culturally influenced. And of late, I've become very interested in geopsychiatry, which is about sort of geopolitical determinants of mental health, of which commercial determinants is quite an important component, and that is how corporations feed us, make us obese, give us diabetes, give us hypertension, and then we have all the sort of psychiatric sequelae related to that, so creating more problems. And we know the rates of alcohol and substance abuse vary across cultures. In France, a child age 9, 10, 11 is given diluted wine, so you're gradually introduced to it. Whereas in many cultures, it's not till you're 21. You can't have a drink, and then you just go, on binge drinking and consequences thereof. And we know that culture affects beliefs and things change. In many, I've been 40 plus years in the UK, and I have not seen a single case of catatonia. Every time I go to India, you see at least one case of hysteria or conversion or somatization. Whereas it's very difficult to find those things in Britain. So what has changed? And that's what some of the things that you need to be conscious about. And we've talked about idioms of distress, and I'm going to cover that. Ethnicity is very much how I define myself, my language, my religion, ancestry, etc. Race has been attributed to biological characteristics, shape of nose, type of hair, skin color. And this concept of race dates back to colonial times, because colonial masters were creating the other. You're not like me, and you're different because of these factors. The concept of racism goes back centuries. I've not been able to find the original source, but there is allegedly a letter from Cicero to Atticus back in Rome, saying don't hire slaves from Britain because they're lazy, indolent, and they don't like music. You know. So that concept of the other existed even then, and race is the most visible one, and people use that. So ethnic groups are self-ascribed, and as I said, that you kind of comparing skin color with geographical origins, which has its own problems. And race is pretty well, it's a social construct, and racism is about, superior race deserves privileges in terms of health, in terms of education, etc. Here we are, that letter to Atticus. And until 1965, and I hadn't realized this, until 1965, whites in the USA were not allowed to marry black because it would pollute their blood. That's what it said. So it is the consequences of that social construct are real. And we then have institutional racism. Because of the culture of the institution, you have this kind of, which is maintained by legal cultural components and creating the other. And there are 87 types of racism. But the most dangerous is missionary racism, which is, I know what's good for you. You poor thing, you can't think for yourself. With the best will in the world, and it looks as if I'm doing the right thing. I'm looking after the weak and the vulnerable. But what that means is that, I'm imposing my values on you. And the other thing that really, really, really annoys me is color blindness. I'm colorblind. I don't want you to be colorblind. Notice the colors, notice individuals. And that goes back to the point that I was making yesterday, is the difference between equality and equity. What we need is equity in health, equity between physical health and mental health, in services and service funding, in research. Equity means according to your need. Equality means everybody gets the same thing, whether they need it or not, whether they want it or not, whether it works for them or not. So, and, the example that I gave yesterday was, give everybody a pair of shoes. Doesn't matter what your feet size is. Doesn't matter whether you like the color or not. Doesn't matter whether you like high heels or not. So there is a danger in sort of simplifying these things. And, again, I'm not going to go through these. They can have excessive slides if people wish. But what racism does is 4 things. It can lead to misdiagnosis. We can blame things and say, it's in their culture. So I don't have to make a diagnosis. I don't have to understand. Which also means that I can be very patronizing and say, no, we don't see that in this culture, so it can't be happening. And that goes back to that missionary racism, that I know better than you do. That arrogance. And then we'll talk a bit more about psychoanalysis and psychopathology and pharmacotherapy in a minute. So what racism also does is that very often, particularly in places like the UK, quite often people from minority groups get excluded. They are in the exclusion criteria of research. And we know that there are genetic variations. We know there are variations related to diet. There are variations related to metabolism, etc. But we never take that into account in any randomized controlled trial. And interpreting that data then becomes problematic. From a research perspective, you have to think about something called category fallacy. Arthur Kleinman, who was an anthropologist and a psychiatrist, he still is, described this category fallacy, which means that the constructs developed in one culture are imposed onto another. And so people get then put into diagnostic categories which they don't really meet. 30 plus years ago, I did a study in North India. We used EAT 21, which is an instrument called Eating Attitude Test 21, developed in Canada. We thought we were being very clever. We translated it, back translated it, retranslated it. And I gave it to about 700 something teenage girls in a small industrial town in North India. When we started looking at the results, 37% of girls had eating disorder. And I panicked. Eating disorders are incredibly, or certainly at that time, were incredibly rare in India. So we went through each question. And there were 3 questions which were causing problems. And one was that food controls my life. So if you're poor and you don't know where your next meal is coming from, of course food controls your life. The other question which was giving us real headache was, I cut my food into little pieces. Now, if you're eating with your hands, without any cutlery, you can only eat small amounts. You're not going to sort of, have a major lump of rice or, whole chapati shoved into your mouth. So there was a clear lesson for me that, you need conceptual translation, not literal translation. And therefore, if you're not aware, you would misdiagnose people in that sense. So now we come to the crux of cultural competence. What do we do? Strategies for culturally responsive assessments. You need to recognize cultural norms. And in this day and age, it's fairly easy to find out. Dr. Google will tell you what's normal and what's not. But at the same time, it's important to have links with community leaders, with religious leaders, with teachers, who can tell you, you need to adapt your interviewing style and pace. You can't rush it. You need multiple sources of information to confirm what's going on. You need to take cultural history, and I'll come back to that. But the key for me is, what does the patient think is wrong with them? What is their explanation? What is maybe completely different from you? Doesn't matter. But it is important to recognize that there is a disjunction between what you think is wrong and what the patient thinks is wrong. As I said earlier, that the patients may want to get a job. I can live with I'm hearing voices, I can live with that. As long as I have some money in my pocket, I've got something to do during the day, and, come home to somebody who cares for me and who loves me, and, simple things in life which all of us want. One of the big tragedies in the UK in the last few years has been medicalization of normal human experiences and emotions. People don't have trauma. People have PTSD. People are not stressed, they're depressed. People, are not really can't concentrate and are a bit restless and, agitated. They've got autism. They've got ADHD. And there's a serious danger in by medicalizing normal human emotions. Not only you're creating more categories, but you're also raising expectations that medication, psychiatry, counseling can cure everything. And if that doesn't happen, patients get more and more frustrated and stigmatize stigmatize the profession, and create problems. Key thing for you, and we heard yesterday, is what's the preferred language of the patient sitting in front of you. Now, quite often, if you're interviewing patients in their second language, people can control. They may not be fully confident in expressing what they would in their original language, in their primary language. So you need to be slightly careful. It's also important that you understand your strengths and weaknesses, and I will come back to that. So you need a range of personal and interpersonal communication skills, both verbal communication and non-verbal. In many cultures, being this close is the way to communicate. Whereas if you're not aware, you feel frightened, patient is being aggressive. They're not being aggressive, they're just expressing in what is culturally appropriate in that sense. In other cultures, being in the same room in that corner is intimate enough. So you need to know what's going on, and how do you then build mutual trust, respect and empathy. So you know cultural similarities and differences, and obviously subtleties of language, body language, non-verbal communication. So cultural competence is basically good clinical practice. No matter who's sitting in front of you, how you treat them. It's not, people from other cultures don't come from the moon. But each individual is different. Two people are feeling anxious, they will have very different explanations. They will have very different ways of help seeking. They'll have very different ways of doing things. So you need to acknowledge that. So for you as clinician, no matter what their culture, race, ethnicity is, you need to work with them to try and find out what works best for them. And it is, training is important, both internal and external, but it is seeing beyond the boundaries of your culture. Quite often we feel very comfortable in our own little patch. So we just need to be very careful that we are not throwing things which we don't understand. When in doubt, ask someone. Someone would know. So this is, it's addressing, so age and generational influences, developmental disabilities, disabilities acquired later, religion and spirituality, ethnic and racial identity, socioeconomic status, sexual orientation, indigenous heritage, national origin, gender. So all these mean different things to different people. For some people, their sexual orientation is the most important thing in their life. For others, it's their religion. For others, it's their gender. So you need to work out with the individual sitting in front of you as to what matters to them. So understand the concept of culture, how it influences human behavior, interpretations of that behavior and evaluations of that behavior. Be open and be willing to identify your own cultural base, values, emotions and thoughts generated by intercultural interactions. Why is this patient irritating me? Is it simply because they're a different culture? Or is it simply because of their clinical condition? Is it because they smell? Is it because something else? So you need to find out the feelings that the patients generate in you that counter transference, even in the first assessment session, is incredibly important. And you need to demonstrate an openness and willingness to develop explore the same things from different perspectives, from diverse cultures, to identify useful and culturally appropriate strategies for working with people. You need cultural sensitivity, degree of cultural knowledge. I mean, there are so many cultures, you can't be an expert in everything. Cultural empathy. In some cultures, if you say, I understand, they will get very angry. You don't understand, you're not in my position, you don't know what I've gone through. So you need to reframe it in a way that I may not be in your shoes, but I can feel. And when in doubt, reframe the question, have I understood you correctly? Have I understood that you really mean this? And that can open other avenues for you to look at. And you need to be culturally aware of your own culture. Gather background information on the community you're serving. In some services, you can have culture brokers or culture mediators. People who come from the same community spend some time with the team, and they can tell the team what the community is, means, and tell the community what the team can and cannot do. It's a two-way process. Establish contacts both formally and informally. And that's where yesterday's stakeholder event was incredibly powerful, because you can forming those links. People are understanding that, this is your bit, you can do it. This is my bit. This is what we can do together. And for this, we may get somebody else. So an awareness and developing those relationships, and quite often, and particularly for lots of cultures and communities, things like myths, folk tales, music, art can be incredibly important in engaging them. But you have to be open-minded about it. And how do you build rapport? Who does the community trust? Just because you are a therapist or a counselor or a medic does not mean that they will automatically trust you. Who do they rely on, and can you work with them? So it's about knowledge, it's about skills, it's about attributes. So knowledge is, understanding concepts and attitudes of things like gender, sexual orientation, micro-identities, patient's culture, knowledge of the impact of racism, poverty, social, economic, educational status, and knowing their pathways into care and explanatory models. Role of language, terms, communication style, impact of social services and policies, and what are the resources available in the community. So for you, ability to communicate is the key. How do you communicate something? How do you express yourself? What words, what terms, what language do you use? Should you be discussing racial differences? Should you be discussing cultural differences? And depends. And for that, again, you need a lot of time to explore what's going on. So you need to understand the role of the language. How do you empower people? Empowerment will mean very different things in very different cultures. And it's your ability to understand that otherism, whether it is misogyny, whether it is homophobia, whether it is Islamophobia, whether it is anti-Semitism. So you need to be aware and apply recent knowledge. Need to be self-reflective, need to be open-minded, be genuine, acknowledging differences, and being willing to work with people. So we talked about explanatory models, and I'm not going to go through that. And again, you need to be aware of the non-verbal communications. In some cultures, people will not look at you in the face. So there's no point you kind of sort of trying to, so you got to look at me. That's the way it is. Facial expressions, gestures, hand movements, style of speaking, pronunciation, rate and volume of speech, how distant they are from you, emotional tone of voice. It may all be that related to culture and beliefs about illness causation, and I'm not going to go through, just to say that you have to be open-minded in understanding that people will have different explanations. And I still recall a patient in their mid-20s who'd been in the hospital for about 10 years, schizophrenia, treated with clozapine, discharged, in sheltered employment. And one day I get a call from the fathers, the family wants to come and see you. Fine. Come and see me. We arrange an appointment. The family arrives. So, okay, how can I help you? Patient is doing very well. He's got sheltered employment. But we think he's possessed. What do you think? So why do you say he's possessed? 1, 2, 3, 4. And what we would like to do is have him exorcised. What do you think? So I sort of looked at them and said, yeah, that's fine, as long as you don't stop the medication. No, we were not thinking about stopping the medication, we just wanted your opinion. And then comes the killer question, could I recommend an exorcist? So I don't know any. So what I did was refer them to hospital chaplain. And to date, I don't know what happened. What they did between the family and the hospital chaplain, I have no idea. But the last I heard, patient had a job, had got married, had 2 children. And for me, that was success. So it is how you frame their explanation with yours and how open you are to those kind of, I could have easily said, that's backward nonsense, it's stupid, nobody gets possession. No, I respect what you're saying. Let's reach some kind of common understanding. You're not going to stop medication. Yay, that's great. So it is, how do we understand that causation and how do we deal with that? And we've talked about psychological measurements, and I'm not going to do that. So tasks for the therapist are you suspend your preconceptions. Not all Indians are going to be alike. There are 1.84 billion. There are 1.4 billion different people you will come across. There are differences in conceptualization. Be aware of the power and the privilege you have. And be aware of racial transference. So race creates the context. Should we be asking questions about race and what it means to the patient? Depends. There's no harm, there's no shame, but don't force it because the patient may not want to talk about it. So you just need to be very careful and sensitive as to what's going on. Race is both personal and social. So
Dinesh, could I ask you about that slide? How would you ask if race is important? How would one even ask her?
yeah, how do you see yourself? And quite often things will emerge. And do you think people are sort of not giving you the job because you're a different color or different ethnicity, different background? Or is it simply about that you're not skilled enough for that job? So you can frame it in those kind of generalities rather than saying, you know, I agree that everybody in this country is racist, and not everybody is. So it's a question of framing it in that context. So you do the mental state examination, you get the third party information, and be very aware of racial transference and counter-transference. In the same way that gender is, what does being female mean to you? And we were hearing yesterday about, particularly in South Asian families, the role of women. If women want to put one step forward, men may say, no, 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 no. And that's a very masculine culture. So how do you deal with that? So part of your job as a therapist is to get the two of them together and say, well, this might have worked 50 years ago in rural India, but even rural India has changed. Difficulty in dealing with some cultural groups is that we think things haven't changed where we left. Things are exactly the way I have this kind of ideal imagination. Country has changed, people have moved on. It's much more forward-looking now than it was in my time. And if I just hang on to that image, and that's part of the tension between men and women in that context, because men are afraid of losing their power. So how do you make them feel that you're not losing your power, you're actually helping empower women who may be vulnerable otherwise? So again, it's a question of reframing that in a way that men don't feel threatened, and they have a role to play in pulling the family together. And it is, again, you can ask, but the gender roles, what is the gender role in your culture? What are the gender role expectations? And those two can be very different things. So you need to be thinking about, and I've talked about culture-bound syndromes, and I'm not going to do that. So we talked about color blindness, and you just be aware of cultural transference and cultural counter-transference, that everything's to do with the patient's race, or everything the patient is feeling is due to the therapist's race. Maybe, may not be, but you may need to explore it in some sense. The key to cultural competence is knowing you. Do you know your ethnic heritage? Are you monocultural? Are you bicultural? Are you multicultural? What messages do you receive from each cultural group? How do these influence your therapeutic work? How well do you recognize your abilities, your strengths, and your weaknesses? What's your worldview? How you see the world? How do you think? And how does that differ from that of the patient? So your personal strengths, your interpersonal supports, environmental conditions, and be aware that some cultures openly express anger, whereas others avoid it. Look at the role of religion and spirituality, particularly attitudes to illness, how people seek help, where they go, folk healing, etc. Stereotyping can be very dangerous. It's effective in the sense that it's a shortcut for us to reach a point, but that's his problem. That not every Indian is going to be vegetarian or non-vegetarian or whatever. So you need to understand why you're stereotyping, and which can be impervious to logic. So this is my second last slide. How do you work with interpreters? I think the key is to have the same interpreter with you in each session. So you understand how you get on with them, how they get on with you, and they understand what you're saying. Um, so you need extra time. You almost need twice as long in your session if you're working with interpreters. Use trained interpreters. Unless it's a matter of life and death, avoid using family members as interpreters. Have a pre-assessment meeting with the interpreter. Try and explain to them what you're going to try and explore. Bearing in mind that interpreters can be frightened, that they may be bringing the culture of the patient into disrepute. Therefore, they may not want to say certain things. And you need to be conscious of that. Reassure the patient about confidentiality, that even if this person is sitting here, it is between the three of us, proper seating arrangements, 3 chairs, but you're asking the patient the questions, not the interpreter. You can't say, well, can you ask her? No, that's not the way to do it. How do you feel? And then the interpreter can sort of ask the question and then give the response and translate it to you. Avoid using complex phrases in discussion, and be aware of cultural, class, and political differences between the patient and the interpreter. Patient may feel that they really can't say certain things in front of the interpreter because it brings their culture and community into disrepute. So we need to be aware of patients' idioms of distress. Idioms do not make clear diagnosis. I think we are more interested in diagnosis than often patients are. Patients but it's also worth bearing in mind the sociological labeling theory. If you label somebody as having condition A, they start to behave that they have condition A. So you just need to be sensitive about that. Acknowledge cultural differences, spiritual values. If you're not religious, you're not spiritual, that's fine. That's your personal experience. But don't denigrate patients' perceptions just because they think that, I'm possessed. And in terms of both pharmacotherapy and psychotherapy, there are no universal models. You need to tailor them. And as I was saying yesterday, that lots of psychotherapies are Western, ego-based. So you need to look at what works for your community and the patients that you're looking after, and then provide them with those therapies. And I touched upon the role of medication yesterday, how different cultures use different ways of medication, types of medication, shape of medication, color of medication, etc. So you need to be sensitive to those kind of variations. And the simplest and perhaps the most important component in therapeutic engagement is respecting patients and the carers' explanatory models, what they think is wrong with them. You may disagree with it. Of course you would, because you're coming at it from a different angle, a professional background, and so on and so forth. But if you sort of wash it off, patients are not going to listen to you. Why should they? You're not listening to them. So thanks very much for being here. I'm happy to take questions now or later. And do we break for coffee now, or do you want? I have no idea what time is. Okay, 5 minutes to stretch your legs and have a pint of gin. Sorry, I didn't say that. Thank you very much.